In this class, we'll be dealing with portal vein and portocaval anastomosis, and a bit in brief about portal hypertension. So, portal vein drains abdominal part of the gastrointestinal tract, except lower part of rectum and anal canal. The peculiarities of portal vein are like this. The most important one is this: begins like veins as capillaries from the gut tube and ends like arteries by dividing into hepatic sinusoids. That means it's beginning as capillaries and also ending like sinusoids. That means both ways. It is not showing any kind of large transformation. Suppose if you see any arteries, they arise as large branches of some other arteries or continuation of some other arteries and ultimately end in capillaries. And if you see veins, they start as smaller capillaries and they form larger veins which drain into further larger veins and ultimately they drain into right atrium of heart. But here at both ends, the portal vein is having capillaries only. Beginning also as a capillary and ending also as a capillary into hepatic sinusoids. Conveys venous blood and absorb nutrient from the gut. Portal vein and its tributaries are devoid of walls, but developmentally valves are present, and it acts as reservoir of blood for approximately one third of the entire total blood volume. Two streams of blood circulates in portal vein. So blood from superior mesenteric vein is conveyed by right branch of portal vein and blood from splenic vein is conveyed by left branch of portal vein. So out of 1500 ml per minute which circulates through liver, 1200 ml is contributed by portal vein and 300 ml from hepatic artery. Perfusion pressure of portal vein is around 8 to 10 mm of Hg, whereas hepatic vein is 5 to 5 mm of Hg. So nutrition to liver 70% by the portal vein and 30% by the hepatic artery. So blood from portal vein and hepatic artery mixes in hepatic sinusoids. These are the peculiarities of the portal vein. So then formation, how does the portal vein is formed? It is formed by union of superior mesenteric vein and splenic vein behind the neck of pancreas and in front of the inferior vena cava. So at the level of L2 vertebrae. So that means if you see behind the neck of pancreas, in the lower half, the posterior surface of the neck of the pancreas, in the lower half it is related to superior mesenteric vein and in the upper half it is related to portal vein. If you observe, so this is the head of the pancreas, this is the body of the pancreas, this is the tail of the pancreas and this is the neck. Okay, so behind the neck, if you observe, the lower half of the posterior surface of neck is related to superior mesenteric vein, whereas upper half of the posterior surface of the neck of the pancreas is related to the portal vein. Here you can see the superior mesenteric vein is joined by the splenic vein to form the portal vein behind the neck of pancreas. And the vertebral level is at L2. So course extrahepatic, that is from its formation from behind the neck of pancreas till the porta hepatis, that is the extrahepatic course, and within the liver it is intrahepatic part. So extrahepatic part is around 8 centimeters in length, 2 centimeters in wide, ascends upwards and to the right behind the neck of pancreas and also behind the first part of duodenum, enters right free margin of the lesser omentum, reaches porta hepatis, divides into right and left branches. So portal sinus is a dilatation of portal vein before bifurcation. Then right branch is short and more vertical, receives cystic vein. Left branch is long and more oblique, receives paraumbilical vein. So this point you should remember. The one tributary which drains into the right branch of portal vein is the cystic vein, and one tributary which drains into the left branch of the portal vein is the paraumbilical vein. Okay, then this left branch is also connected with ligamentum teres hepatis from below and ligamentum venosa from above. You can see here. So this is the formation of the portal vein behind the neck of the pancreas, splenic vein joined by the superior mesenteric vein forming the portal vein. So here pancreas has been removed. So this is behind the pancreas and this is behind the duodenum and this is within the right free margin of the lesser omentum. So this will be the infraduodenal part, this will be the retroduodenal part and this will be the supraduodenal part. So we'll be studying the relations of the extrahepatic part of the portal vein in these three segments. You can see here infraduodenal part, relations are like this. In front it is the neck of pancreas as I have shown in the earlier diagram. Behind will be inferior vena cava and right side will be bile duct. So throughout the course, the posterior relation is inferior vena cava. So infraduodenal part, in front it is neck of pancreas, behind inferior vena cava, right side it is bile duct. So retroduodenal part, as the name itself speaks, retroduodenal, that is behind the duodenum. So in front The relation will be duodenum, the first part of duodenum. So between the portal vein and duodenum, there is bile duct on the right side and gastroduodenal artery on the left side. And this also you should remember, this is one specialty. Gastroduodenal artery is not having a accompanying artery, and even the prepyloric vein, sorry, gastroduodenal artery is not having a accompanying vein, and prepyloric vein is not having an accompanying artery. Please remember, gastroduodenal artery is not having any accompanying vein, whereas prepyloric vein of Mayo is not having any accompanying artery. So then behind, you can see inferior vena cava. So in both the parts, you can see the posterior relation is inferior vena cava. So as this was intraduodenal, and in other words, we can also call it as retropancreatic part. So in front is neck of pancreas, behind is inferior vena cava, right side is bile duct. And this is retroduodenal part. In front is the first part of duodenum, behind is the inferior vena cava. So between the first part of duodenum and the portal vein, there are two important structures. More towards the right side is the bile duct, and more towards left side is the gastroduodenal artery. And two important points for next exam in this slide is that gastroduodenal artery is not having any accompanying vein, and whereas prepyloric vein of Mayo is not having any accompanying artery. So then the last part, the supraduodenal part, it is within the lesser omentum. So in front and to the right, there is bile duct. In front and to the left, there is hepatic artery. So bile duct, hepatic artery, and portal vein. These are the three structures which are present in the right free margin of the lesser omentum, which also forms the anterior boundary of the epiploic foramen. So behind, there is inferior vena cava separated by the epiploic foramen. So at the porta hepatis, the relations are like this from before backwards. So first relation will be right and left hepatic ducts. Then behind that, right and left branches of hepatic artery. And next to that, or posteriormost structures will be the right and left branches of the portal vein. Note, right and left branches of the portal vein supply physiological left and right lobes. You can see here the intrahepatic part. The branches of the portal vein along with branches of the hepatic artery and bile ductules pass through portal canals in interlobular spaces of liver. So the branches of portal vein along with the branches of hepatic artery and bile ductules. Okay, there are three contributions here. So branches from hepatic artery, branches from portal vein, and also bile ductules. All these three travel in portal canals. So these portal canals are surrounded by Glissen's capsule and is separated from hepatic lamina by space of Moll. So these spaces you will understand once we deal with the histology of the liver. So portal radicals of the canal convey blood to hepatic sinusoids through the inlet venules. So next, after providing nutrition to hepatocytes, blood is conveyed to the central veins. Central veins unite to form sublobular veins. Sublobular veins unite to form hepatic veins. Hepatic veins drain into inferior vena cava after piercing the groove for inferior vena cava of the liver. So this is the flow in the intrahepatic course. If you see, portal vein dividing into branches, and those smaller branches passing through portal canal along with hepatic artery branches and bile ductules, reaching the hepatic sinusoids, conveying the blood here. So here they mix up with the blood of the hepatic artery, and also hepatocytes are exposed to this blood here. Then the hepatic sinusoids convey blood to the central veins convey to the sublobular veins convey to the hepatic veins convey blood to the inferior vena cava, which ultimately drains into the right atrium of heart. So tributaries of the portal vein, formative tributaries are superior mesenteric vein and splenic vein. Tributaries of the trunk are right gastric vein and left gastric vein. Tributaries of the right branch, cystic vein, and tributaries of the left branch, para-umbilical vein. So please remember this. The right branch receives cystic vein and the left branch receives the para-umbilical vein. So occasional tributaries are inferior mesenteric vein, right gastroepiploic vein, and prepyloric vein of Mayo. So portocaval anastomosis sites, the lower end of esophagus, lower end of rectum and anal canal, umbilicus, behind peritoneum, bare area of liver, falciform ligament, and fissure for ligamentum midosum. So at each space we will see the portal component, caval component, and important clinical manifestations. If you see the lower end of esophagus, it is the left gastric vein is the portal component and hemiacegus vein is the caval component. The esophageal branches of left gastric vein and hemiacegus vein will anastomose. Okay. In portal hypertension, there will be esophageal varices, which ultimately after rupture leads to hematemesis. You can see here. So this is the left gastric vein, esophageal branches of left gastric vein, and the esophageal branches of the hemiesophagus vein. To be specific, tributaries of these two veins are joining at the lower end of esophagus. This will be the portal component. This will be the caval component. So then, at the lower end of rectum and anal canal, the portal component is the superior rectal vein, and the caval component is the middle rectal vein and inferior rectal veins. So portal hypertension results in internal rectal piles. You can see here. So this is the superior rectal vein, which is the portal component, and this is the middle rectal vein and inferior rectal vein, which are the caval components. So I'll show you in this. Yeah, you can see here clearly here. So this is the superior rectal vein, which is continuing as the inferior mesenteric vein. This is the portal component, and here you can see this is the middle rectal vein, and this is the inferior rectal vein. So these two are the caval components, portal component and caval component, anastomosing at the lower end of the rectum and anal canal. So where portal hypertension results in hemorrhoids or internal rectal piles. So now at the umbilicus, the portal component is the paraumbilical vein, whereas caval component, you can see 6 veins: superior epigastric vein and lateral thoracic vein from above, superficial epigastric vein and inferior epigastric vein from below, posterior intercostal veins and lumbar veins from either side. And ultimately, the portal hypertension results in a clinical conditions called caput medusae. I'll show you in these figures. You can see here. So from above, you can see this is the superior epigastric vein, and you can see here this is the lateral thoracic vein, and you can see from the sides posterior intercostal vein and the lumbar vein, and from below you can see the inferior epigastric vein and superficial epigastric vein. So ultimately, the portal hypertension results in caput medusae around the umbilicus, the wheels of a spokes. So then behind the peritoneum, the portal component is splenic vein and colic vein. And the caval component is left renal vein and tributaries of inferior vena cava. And there are small tributaries which communicate them. So these are called as veins of Retzius, small veins connecting portal and caval tributaries retroperitoneal. Veins of Retzius. So then in bare area of liver, the portal radicals of liver and the caval component is diaphragmatic veins. So in the falciform ligament, the portal component is paraumbilical vein and caval component is the diaphragmatic vein. So connecting these two veins, there is accessory portal system of Sape. What are these small veins communicating paraumbilical vein with the diaphragmatic veins? Then fissure for ligamentum venosum, the portal component. The left branch of the portal vein at porta hepatis communicates in fetal life via ductus venosus. Okay, with inferior vena cava, the caval component. So after birth, so this ductus venosus converted into ligamentum venosum. So ductus venosus fibrous to form ligamentum venosum. In rare cases, ductus venosus persists and establishes direct portocaval anastomosis. So development of portal vein. So this develops from infrahepatic part of the right and left vital veins which drain yolk sac and reach liver on either side of the gut tube. So around duodenum, vital veins are connected by 3 transverse anastomosis, cephalic and caudal ventral anastomosis, and a mid-dorsal anastomosis. So 2 ventral anastomosis and 1 dorsal anastomosis. Splenic vein joins the left side of the mid-dorsal anastomosis, and U-shaped loop of duodenum is encircled by figure of 8 anastomosis. So there will be 2 circles, like here you can see. So this is figure of 8. So this will be the cranial ventral anastomosis. This is the caudal ventral anastomosis. This is the mid-dorsal anastomosis. Now this posterior part will disappear and this anterior part will disappear. Only the anterior part of the lower circle, dorsal anastomosis, and the posterior part of the upper circle. So these will form the portal vein and the superior mesenteric vein. You can see here. Due to rotation of duodenum to the right side, posterior limb of the lower circle disappears. Anterior limb persists as the superior mesenteric vein, which passes in front of third part of duodenum. Then anterior limb of the upper venous circle disappears. Posterior limb formed by dorsal anastomosis and part of the right vital vein. So all these forms the portal vein. You can see here, as I said, the posterior limb of lower circle disappeared, anterior limb persists as superior mesenteric vein, the dorsal anastomosis and the posterior limb of the upper circle. So they are forming the portal vein. So right vital vein above cephalic ventral anastomosis forms right branch of portal vein here. So above the cephalic ventral anastomosis, this forms the right branch of portal vein, and the cephalic anastomosis and the upper part of the left vital vein form the left branch of the portal vein. See, this thing will be the left branch of portal vein. That's why the right branch is shorter and left branch is longer. This explains why left branch of portal vein is longer than the right branch. So importance of portocaval anastomosis: portal obstruction due to cirrhosis of liver. So this results in backflow of portal blood. and the radicals of porta caval anastamosis will allow the blood to reach right atrium, that is at the lower end of esophagus, at the lower end of rectum and anal canal, around the umbilicus. All these areas there is porta caval anastomosis, which will open up and allow the blood to flow back through the caval system to the right atrium. If anastomotic channel is impervious, ascitic fluid accumulates in peritoneal cavity due to venous stasis, and hematemesis results due to ruptured esophageal varices. So portal hypertension is a frequent complication of cirrhosis. Other causes also there. The normal hepatic venous pressure gradient, that is difference between the wedged hepatic venous pressure and free hepatic venous pressure, is 5 to 6 millimeter of mercury. And clinically significant portal hypertension is present when the gradient exceeds 10 mm of Hg. So normal is 5 to 6, but if it exceeds 10, then there will be clinically significant signs of portal hypertension. And risk of variceal bleeding increases beyond a gradient of 12 mm of Hg. You can see the causes for portal hypertension. So if you see the prehepatic and pre-sinusoidal, the most commonest cause will be the portal vein thrombosis due to sepsis, but also procoagulopathy or secondary to cirrhosis, or there might be abdominal trauma including surgery. And intrahepatic pre-sinusoidal causes are like schistosomiasis, congenital hepatic fibrosis, drugs, vinyl chloride, and sarcoidosis. And the sinusoidal causes are the most commonest. See the importance, the cirrhosis, most commonest, then polycystic liver disease, nodular regenerative hyperplasia, metastatic malignant disease. Then intrahepatic post-sinusoidal is the veno-occlusive disease. Post-hepatic post-sinusoidal is the Budd-Chiari syndrome. The most commonest cause will be the cirrhosis, which is at the sinusoidal level. Complications of portal hypertension are like variceal bleeding, esophageal, gastric, and others. And then congestive gastropathy, hypersplenism, ascites, iron deficiency anemia, renal failure, and hepatic encephalopathy. So surgical treatment for portal hypertension. So portosystemic shunt surgeries like egg fistula operation, where surgically portal vein communication between left renal vein and splenic vein with or without splenectomy. So surgical porto-caval communication is established between left renal vein and splenic vein, either keeping the spleen intact or removing the spleen. And the other procedure is transjugular intrahepatic portosystemic stent shunt. I'll show you in the next diagrams. You can see here the splenic vein is grafted to the left renal vein. So whatever blood is coming here, it is going into the left renal vein, and ultimately it goes to the inferior vena cava, and then it goes to the right atrium. So it is bypassing the liver. So the other surgery is like transjugular intrahepatic portosystemic stent shunt. You can see clearly here. So what is happening here? There will be a guide wire which will be passed through the uh, superior vena cava, right atrium, inferior vena cava, and through the hepatic vein it reaches a part of the liver. So this part of the liver segment is damaged, and it gains access into the portal vein. So now the blood from a branch of portal vein is directly guided into the hepatic vein and ultimately into the inferior vena cava and to the right atrium of heart. So this procedure is called as transjugular intrahepatic portosystemic stent shunt. Thank you.